All right, welcome back. Now, here's what we do now. There's a cholera outbreak in northeastern and some parts of Syria, and then there's also a row in terms of measles immunization between the Catholic Church and the government. I want to put some of these matters in perspective and also in context. And to help us with that, today we're joined by Dr. Githinji Gitahi, who is the Group CEO of AMREF. He's going to be talking to Mutegi Njaran. We want you to join the conversation as well. You can talk to us using the hashtag PowerBreakfast, that is on Twitter, and you can also talk to us on 22422. That is our SMS number. That number again, 22422. Send in your comments, your views, and your suggestions for the same. Mutegi?
Thank you, Abu. Welcome, Dr. Asante. When a tragedy like a cholera outbreak takes place in this country, and you know that the health is being devolved, it is a business of the county or the Minister of Health to deal with it.
Yeah.
How does AMREF come in?
AMREF comes in as a non-government organization. For us, our mandate is we are not a for-profit company, so therefore we are what we call non-state actors in the health industry. So we work together with the Ministry of Health to assist and to complement the work of the Ministry of Health across both central government and counties. And therefore we come in to complement what they're doing. Not all the time that the ministry will be able to respond to every epidemic or even every health issue. And sometimes they'll need skill, emergency response, and that is our role. Yeah.
So what is the situation now in Mandera?
The situation in Mandera is that you know, we have quite a number of people who have caught cholera, and this has come from other counties that were earlier affected, like Wajir. And also, you know, Mandera is at the border of Ethiopia and Somalia, and that small angle there is also we are getting cases coming from Ethiopia, cases coming from Somalia as well, and now the situation is that close to 800 people have been recorded since April 13th. So within a very short time, we have a very huge number affected. And unfortunately, by yesterday when I went to visit Mandera, 11 people had died of the cholera epidemic. So the situation is such that on the ground, the government of the county government is trying to do the best that they can. You know, I didn't have any evidence that the central government had come in yet. So when I talked to the team there, they were still working within the resources of the county government. And part of the challenge that they have is that we have a very new crop of health workers. Because as you know, before devolution, places like Mandera had only a total of 150 total community health workers in a whole county. Now they have raised these numbers to close to 800. But these people are not very well trained in managing epidemics. So this is the challenge. Number two is a challenge of space. When you have so many patients coming in at the same time, and these are patients who need isolation. They're not patients that you admit with everyone else. You don't have enough ward capacity. So we come in as AMREF, and also when I went there yesterday, I found that MSF, one of the other NGOs, has also responded to help the county to put up what you can call cholera treatment centers. These are like makeshift wards outside the main ward. You have to tent them, you have to put beds in there. Now the government, as you know, it's a very slow machinery. So when you have to do these things in a hurry, the government takes time. But people like us can respond, and respond quickly to complement the other services that the government is putting together. So this is where we are. And the situation, I was with the governor yesterday, they really need help because the cases continue to increase, and and most of the cases are quite severe, that we're able to say.
Cholera actually is a hygiene problem.
Yes.
Mainly either you have no water or you have water which is contaminated.
Correct. That is the issue.
It's a thing that can be prevented or controlled.
Yes.
Why is it becoming rampant then?
You know, the system is it's a bit complicated. You are absolutely right. It's an issue of hygiene, water, food. So in a situation like Mandera, Wajir, Tana River, these are the counties that have been affected largely. What you find is that you get somebody coming into the community with cholera. And when they come to the community, you find a community first that has water scarcity. Because you know these communities, these counties don't have a lot of water. So they have water scarcity, and therefore they're also recycling and reusing water. So that's the first problem. Then, in the food places where they eat, they're also reusing water. Maybe the water used to wash dishes was also used to wash other dishes, this kind of thing. They don't have a lot of room to throw away water. Now, when therefore you get one person getting in and affecting or infecting 2-3, those 2-3 go home. and they share water again. They share the utensils with the family. So it spreads very rapidly. The other problem is that you have a lot of people who don't have access to clean toilets. Mutegi, we take it for granted that people have access to toilets. People don't. In fact, the statistics we have is that there are more mobile phones in this country than there are toilets. And access to mobile telephony is higher than access to toilets. This means that people then can have open defecation, can have contamination of water sources. So the control of cholera has to start back in the community. Train the community to wash and rewash their hands. Train the school children to wash their hands, to educate their parents. On top of that, you have to ensure that any case of cholera is isolated. That is actually one of the biggest problems, because the infectious ability is very high. So if you don't isolate the case, even before you start treating the one that came in, another 10 have already been infected and are infecting another 10. So this is the challenge. Yeah. I understand even apart from cholera, there is another disease which I've never heard. I'm hearing for the first time today. Yes. Chikungunya. Chikungunya. Yes. What is that? What's chikungunya? The chikungunya virus is a virus that was discovered largely at the border of Tanzania and Mozambique some time ago. And it is a viral disease. Is caused by a virus which is transmitted by the mosquito, and it causes fever, joint pains. And the word chikungunya actually originally from Zambia, sorry, not Mozambique, Zambia, means bent over. That's what it means. So the patients actually have a bent over, that's what it means. And it has come from some of the sides of Somalia, come into Mandera, and has affected quite a number of people. Yesterday when I was there, they were saying close to half the health workers have been affected by chikungunya, and therefore they have to take days off. The lucky thing is that chikungunya is rarely fatal, so it rarely kills. It has 3-4 days and then disappears. So it's not something that we are scared of in terms of killing people. The biggest problem is in terms of its effect on the health system, because if you have a lot of people, they still have to come to hospital, and the hospital has to take care of them, and yet you have another epidemic of cholera that requires people to be admitted. This is a big challenge, but it rarely kills. So where is the origin of this chikungunya now in Elteri, Mandera? Where did it come from? It is thought that it's crossed over from Somalia. So there is a likelihood of somebody traveling from Mandera and bringing it to Nairobi? Yes, there is. How is it transmitted? It is transmitted through mosquitoes. So it is just like malaria. So a mosquito bites you and then bites me and then I get it. So there is a big part of which there is also a public health issue of controlling the spread by spraying, making sure there are no, this rain that has been there, that we have had excessive rain as well in these areas. And therefore you have many areas which have pooled water. And this water is also what is breeding the mosquitoes. So there's a public health issue of making sure we drain all pooled water, and also we spray the forest so that the mosquitoes can die. That is the easiest way of controlling the chikungunya problem. So what is being, because of those two problems, what needs to be done in Mandera? What needs to be done in Mandera is quite a number of things. Number one is that there is immediate need to take care of the patients who are in the ward. The numbers are big. Yesterday I think they had 71 patients. Now when you have a hospital like Mandera Referral Hospital with 71 patients who require isolation, not in a normal ward, that's a crisis for the hospital. So most of these patients are in the corridors. They're outside in an area where people are being sprayed before they can enter, and they're there with their relatives. So number one is to take care of those patients, to get them IV fluids urgently, because one of the problems of cholera is the diarrhea dehydrates the body very rapidly. So there is a need to provide commodities to rehydrate the patients, antibiotics to treat the patients so that they can heal quickly. Then there is need to provide the health workers with gloves, protective equipment, so that they also don't get affected, they don't get infected. There is the other need to provide space for those patients. So there is the immediate need, and that is what we are working on with the Mandera County government to achieve in a very, very rapid time. The next thing is to educate the health workers on managing and isolation, and also educate the public health officials and help the county government to educate the public health officials on managing cholera outbreak, and also to educate the communities themselves so that we can stop the spread of the disease. So it's all the way from the emergency backwards, and then that will mean that we only don't stop in Mandera. We have to go back to Ajir, we have to go to other counties. So it's not a Mandera only problem. It's only that Mandera now is the most affected. So far 6 or 7 patients have died from January alone to now, 6 or 7. So So what we are doing as AMREF is we have gone back, we've gone in an emergency situation, but we are also asking the public and institution and anyone else who has funds or resources to help us in the short term, so that even by the time the whole Ministry of Health machinery comes to life, we'll have saved significant lives. So as AMREF, we've started a fundraising campaign, and you know, probably we'll be talking a little more about it, but we're looking for about 25 million Kenyan shillings only, and that will be able to help the county build a shelter, buy commodities that are needed, train in the communities, the schools. So it's a whole package of things that need to be done.
So when you say you're fundraising, means what? How are you fundraising?
What we are doing is we are asking the public in Kenya to send money through M-Pesa, and because then this helps us to get some money that then we can put into this cause, because we don't generate our own money. We are a public non-state actor organization. We are an NGO. So what we've asked now is that we have released information that if somebody sends, we have a hashtag, I think it's *299*100#, and we can give that more information on our website, our Twitter page, but people can actually send money, and that money is what we are putting directly to the work that we're doing in Mandera right now.
Can you say, maybe give the public, whoever wants to give the money, can you just do it now?
Yes. What you can do, if you want to give money, you can send your M-Pesa donations through paybill number 000557, 000557, and you can also go to your phone, dial *229*100# and send money. So those are the two ways that you can send money. But for corporations, you can call us directly, and because some corporations may want to donate in terms of checks and this kind of thing, so you can call us directly and we can organize that. And we are only raising 25 million because that's what is needed to at least stop the spread and also push back the infections that are coming up.
Yeah, there has been a campaign also by the government to inoculate vaccination of against diseases like what are they called, against rubella and measles.
Yes, correct.
First of all, tell us what rubella is. People know measles. What is rubella?
Rubella is actually called German measles. So it's like measles.
Measles.
Yes, so it's very similar to measles in terms of its effect. But the complications of measles, the complications of rubella are different. Measles, as you know, affects young children. They get a rash, fever, watery eyes and this kind of thing. And if it's not treated in time, it can cause actually brain complications. And it's one of the causes of deafness and blindness in this country, people that people don't know about. Rubella, on the other side, the biggest danger of rubella is that if it infects women who are pregnant, the children actually get congenital malformations. So, and we know recent data shows
congenital malfunction.
Yes, malformations. Children are born with complications which came up during their development.
Okay.
Yes, and could be many and different. And one of the things that we never really thought, and this is why rubella is new to Kenyans, we never really thought that there is much rubella in this country, but there is. Actually, we've seen that a huge percentage of the cases of people diagnosed as if they have measles actually have rubella in this country. So we now have the data, and that is why the government has come up and said now we can no longer avoid vaccinating people against rubella. We didn't have rubella vaccination here unless you went individually to a private hospital and you asked the doctor for rubella vaccination. But now it has entered the public health arena, and it is recommended by WHO that it is given together with measles, with the measles vaccine. So this is what the government is doing, and it is a necessary vaccination if we are going to hold back rubella and measles spread.
Is this for only children or women? If rubella affects women and then they have malformed children?
Yes.
Are we vaccinating only children or women also?
Well, right now we are vaccinating children, but the government is saying it's up to 60 months. That should be up to about 15 years. So they're being vaccinated early, because when you vaccinate children up to that age, you also vaccinate girls who are entering the reproductive age, because it's not an immediate vaccine. It actually works for many years. So you just need to make sure that as the girls enter the reproductive age, they have had vaccination for rubella. In fact, you should not vaccinate women who are pregnant with rubella, because then even after a woman receives it, they should not be pregnant for the next 3 months, because you want to allow the active phase of the vaccine to go away, so it doesn't affect the baby if you're pregnant.
The intention of the government actually was to targeting about 20 million, 19 million people.
Close to 20 million people. And I think they are fairly there. What I've seen now from the Ministry of Health is they've reached more than 16 million.
Yeah, actually they're saying they've done 18. They have added another 2 days.
Yes.
In certain counties. So that they can get to
200% of the 19 million expected. And this is really what the government is doing, the right thing. It is not only in Kenya, it's happening everywhere else, and it is important now that people understand it is necessary and mandatory.
Necessary and mandatory.
Yes.
And here comes the then of the church, particularly the Catholic Church.
Yes.
And there was this nun who was arrested yesterday, and she refused Nakuru. She refused the children to be vaccinated, vaccinated against the disease. What do you say to that?
You know, my view on this issue is that it's actually a non-issue. The Catholic Church is bringing up an issue and denying children their right to good health. That's my view. That's my honest view. Health is a right. And this issue about whether children should be vaccinated or not, and the debate as to whether it should be mandatory or not, it's not only in Kenya. You know, last year there was a case in the Supreme Court of the US regarding some kids who are supposed to be going to school, but the school said unless you get vaccinated you cannot enter the gate. And the parents went to court and said, you know, they are being denied their constitutional right. And the Supreme Court ruled against the parents and said mandatory vaccination does not go against the constitutional right of a child. So for the Catholic Church to come and say we are not going to vaccinate children, number one is that you need to give the parent the right to choose, because this child, at first, the first guardian is the parent. So if they were saying that we call the parents here and we ask them to make a choice, and these 3 parents say their children should not be vaccinated, why is the Catholic Church making a decision on behalf of the parents? When these children get infected, whose responsibility is it going to be? So for me, it is something the Catholic Church needs to wash its hands off and leave the parents to make decisions on behalf of their children. And even the government can still override the decision of the parents and ensure that children get vaccination, because it should be ideally vaccination for public diseases like this should be mandatory.
Is the Catholic Church, the fear is that these vaccinations are not for the disease. They think there is something to do with family planning, that the vaccines are laced with things that will make girls, particularly the girl child, or not give birth. Is that scientific? Is that fear justified? It is absolutely unjustified scientifically, because we know the chemicals they are talking about. You know, sometimes if you take this water here that you are taking here and you take it to a lab and analyze, there are many things you might find here that you didn't intend to drink in the first place. You thought you were just drinking H2O water, but there are so many other things in these components. Now, the quantities of those things that you may find in the vaccine have no correlation with the effect that if you wanted them to act as family planning drugs, you need a much higher dose. They are prescribed doses. You know, now, even when I talk about a drug like aspirin, Mutegi, I can tell you that aspirin at a small dose has no effect on pain, but it has an effect on your heart. But at a certain dose, it has an effect on pain. This is how chemicals work. You see, so the fact that somebody could have found a small compound, that they used a machine that identified as a small compound that could be related to a family planning, has absolutely no scientific evidence that it can actually sterilize or affect young girls. The other thing is, you know, we know very well that women take family planning medicines, but they don't take it 1 month and then they say, now because I took it last month, I'm now free from getting pregnant for the next 100 years. There is a reason why it's taken every day, every month, because the protection is actually measured to be able to, you know, it is affecting the body in a particular way, and therefore you can't say because you took a pill with this one day, now you're vaccinated, you are sterilized for life. There's no scientific evidence at all. Initially, the Catholic Church was against the vaccination of women against tetanus.
Yes.
And there was a big quarrel.
Yes.
Including the cardinal.
Yeah.
Making those, telling the Catholics don't take
the tetanus jab.
What's the connection between the tetanus jab and the measles?
And the measles. The difference between the two, the connection between the two is that the Catholic Church is seeing shadows, fear in shadows. That is the connection. There is no scientific connection. The issue is this: the tetanus jab is, you know, when women get pregnant and they go for antenatal care, the first thing they get is a tetanus jab, because you don't want a woman who is pregnant to actually get tetanus. So you protect them, irrespective of whether they have it or not. You protect them.
So anyway, generally, a woman who is pregnant is going for clinic will get a tetanus jab. So whether the Catholic Church refuses or not refuses.
Even now, they get and have been getting. Even when I used to be in practice in the clinic, the first thing you do when you get a pregnant woman is you give them a tetanus jab to protect them.
In fact, anybody who gets cut, anyone
who gets cut gets a tetanus jab. Now,
so that argument by the Catholic Church looks to me as if it was...
Yes, it is, you know, pulled out of air, because the next thing is that now the government said that because this regular antenatal vaccine may not be accessed by all women, so the tetanus issue is still big in this country, because not all women get the jab when they go to the clinic. So why don't we vaccinate all women in the reproductive age, so that whether their doctor or their nurse remembers to vaccinate them when they go or not, they are already protected. So you then target the women who are in the reproductive age. That already tells the Catholic Church, why are they targeting women in reproductive age? There must be a problem. You get, that's where I'm talking about
shadows. Don't target men because men don't give birth.
Yes.
The man will not need a tetanus when you are cut.
Thank you, Mutagi. You see,
why can't the Catholic Church understand that?
You know, the medical community tried to explain this. The Ministry of Health even appointed a team of specialists. The church appointed a team of specialists who, I'll tell you, because some of them are people I knew, were even ashamed to discuss this thing.
Because even a cardinal, if he had an accident, God forbid,
he'll get a tetanus jab.
And goes to a clinic. Even if he went to a Catholic hospital,
he'll get a tetanus jab.
Even if he went to a Catholic hospital,
yes, he'll get a tetanus jab. Yes. So it is just seeing fear in shadows. That's it. That would be my conclusion. And therefore there is no relationship between that and measles. If the measles issue is still, you could be sterilizing people, it is the same fear, but there is no scientific connection between the two.
Apart from those two, we have a problem of, there was a campaign and a moratorium to kick polio out of Kenya.
Yes.
How successful has it been? Polio is almost gone all over the world.
It's almost gone all over the world. I think in Africa now, it's only Nigeria where we have a few cases.
But you had the polio vaccination the other day.
Yes.
Why?
Because there is something always called the reemergence of a disease. So you don't want the disease to reemerge because it's a very difficult disease to control, and it is very expensive on public health resources. So the fact that you've actually cleared it, you always have to keep your eyes out for any possible reemergence. So sometimes when there are signs of reemergence, you may see maybe one case, then you have to do a public health vaccination.
I think there was a case of some fellow traveling from West Africa, went to Somalia.
Yes.
And then from Somalia it came to our refugee.
Yes, to the refugee. Yeah. So now when you see that, you don't just go and say, we are now going to vaccinate this community, because it's such an expensive disease. Even on the effect of the human being, on the people who get affected, they get paralyzed. So the government finds it necessary to actually vaccinate everybody, and that is actually what the government was doing with the polio vaccine. So, and that will continue. It's not going to end.
Now, you have this chikungunya, and we are going to have the Olympics in Latin America. We have a problem there called Zika.
Yes.
Should we go or should we not go?
We should go, I think. We should go, Mutagi.
What if we bring it here? Is Zika anywhere in Africa?
Yes, it is. A case has been picked up in Cape Verde, and therefore, there is WHO now is alert on Zika in Africa, seriously so. The big issue with Zika is that, first, it will infect people, but the biggest effect is that if it infects a pregnant woman, then the child ends up with a skull malformation, which a small head, and this is really the big issue. So it's been spreading. It's a global health issue.
It's also a mosquito problem.
It's also mosquito. It's also mosquito, and therefore the biggest thing is to ensure that people sleep under mosquito nets. And also, this is the other complication, people haven't realized that Zika is also sexually transmitted. So
and some country, I think some country are sending their athletes
Yes.
With condoms.
Yes.
Anti-Zika condoms. I saw that in CNN, I think.
There's a recommendation that pregnant women use condoms in areas where Zika has been noticed, because it can be sexually transmitted. So even if you don't get bitten by mosquito, your man bitten by a mosquito can also transmit Zika.
So what are we going to do with the athlete?
I think the most important thing is to just use the normal protection. You know, if you are going to an area that has Zika outbreak, just like if you're going to an area that has malaria, you use a net. You make sure you always sleep under a net. So the same mechanisms used to protect ourselves against malaria are the same ones that we should use to protect ourselves against Zika. So it's a net, mosquito repellent, so the usual thing. So that's what our athletes need to do.
Not condoms?
Well, if I would assume that they are not going to be having unprotected sex anyway.
Anyway, but tell us about AMREF and the vaccinations. What's your role in terms of these inoculations?
Our role is, you see, our role as AMREF across, Africa, where we work, is to strengthen the district health system, which is the government health system, to help the government to strengthen its health system where it's weak. So we will find us working in countries like South Sudan. Now we are getting in Somalia, we are in Senegal, we are in Tanzania, Ethiopia, all these countries. And we work with the government to strengthen the government health system. So in vaccination, we would strengthen that by, number one, educating vaccinators, the people who are supposed to vaccinate, educating them on the key public health issues, providing education on what we call the cold chain management, because vaccines, again, have certain temperature ranges they need to be stored in. So we have to educate the people to ensure that all the vaccines are kept well. So this is one of the roles that we play. The next role is, after we strengthen the government health system, is to come down here to the community and say the community needs to access government health system. So we now start to strengthen what we call the community health systems through training community health workers. We now use mobile phones to train community health workers, train them on vaccination, on cholera. Like now we are going to be using this to train health workers in Mandera, tell them how to respond to cholera, because this makes sure that information spreads rapidly and the people then know exactly what to do. So we are also working communities. Actually, that is where we are known for, to work with the communities. So for now, in Mandera, we are going to be training these people, training the public, training the schools. So we also have programs for schools like we call personal hygiene and sanitation. We call it FACE. And we go to schools and train young children about health and sanitation, hygiene and sanitation. What happens when your child is taught? They come home and they teach the parents. That's what they do. So it becomes a very good ground to spread the information. So this is our role. And beyond that, it is to do what we call advocacy, to provide scientifically based information to the public and to the government to ensure that we guide policy. So we'll go to the communities and do research, and we'll come and tell the government, based on research that we've done, if you did this, this would be the effect. And that helps government to make decisions when they're budgeting, when they're making policy changes in the healthcare. So this is where we play.
I saw in the newspaper the other day that government is voting about 42 billion shillings for toilet sanitation,
yes,
and petrol streams. I remember when I was young, it would cost nothing to do a petrol stream.
Yes.
Or the need chief comes here and says, look, according to what your homestead is, look like, go and dig a petrol stream somewhere below the homestead.
Yes.
And that will be done. And if it's not done, the man, the owner of the house, will be arrested by the chief.
Yes.
Why are you saying that we have more mobile phones than toilets? Well, it is as simple as that.
Yes. There are many problems. Now, if you went to Kibera now, or not only Kibera, in one of the slum areas, and you tell a household to dig a toilet, they don't know where to do one, because
there's no area.
There's no area. Yeah. The only area they have is where they sleep.
Yeah.
So that's one big problem. It's about access to the land and to the space.
But Mandera and northeastern country,
in those places is the next problem, which is pastoralism and migration. So these people live here for 3 months, then they move on to go to another place. So
there's nothing fixed.
There's nothing fixed,
and you can't have a mobile toilet.
They can't afford it. I'm sure they're available here, but they can't afford it. So they end up with what you call open defecation. So they throw away, as they go. So this is the challenge, and it's global. It's not only in Kenya. Yeah.
So what about in areas that, like Central Province, Nyanza, where people are not livestock farmers? They remain in their homes.
In those places, the prevalence of toilets is very high. The access to toilets is very high in some of the provinces. In Central Province, in most of the areas that are agriculturally led, not trade and livestock, those areas have very high density of toilets. So those are not the focus of government. The focus of government is out here. But also within those areas, the other problem you have, and I'm sure, you're from the village, I'm from the village. We know families that have toilets and then they would fill up and they wouldn't know what to do with them. So that's also part of public health. That's also part of the government to say, this is what you need to do. This is where you need to put the toilet. Don't put the toilet where the water, your water pipe is coming through, remove it from here and relocate it. So this is also part of this fund. It's not only about have a toilet, but have the toilet that is quality and in the right place. Remember there was this whole discussion also about ventilated toilets that people started doing where there is a pipe releasing the air up. That's also part of it. That we have toilets but they are not ventilated. So again, it also increases the possibility of having house flies and all these things. So it is just beyond having a structure, a physical toilet. Yeah.
Thank you very much, Dr. I think you'll make your money. Maybe you can repeat the numbers again.
Yes, let me repeat the number again. Yes. The number is, I'll give it to you right now. So, our number is 000557. That's the pay bill number, 000557. And for anyone who wants to go through, the normal text USSD, it is *229*100#. *229*100#. Or you can just call us or write us an email or go to our website. You'll be able to contact us and you can help us to help the people of Mandera and the other counties stop.
And all you need is 24 million.
We just need 25 million.
Thank you very much, Dr. I hope Kenyans will come to your assistance because we need to save the lives of the people who are affected by this cholera problem. Thank you.